Respected audience, Assalamu alaikum. I am Professor Shamsudjaman, Professor of Pathology. I welcome all in today's 13th lecture on hematology. Today, day 3 of hemorrhagic disorder. Today's topic is von Willebrand disease. Today's topic is von Willebrand disease. Before going to discuss about von Willebrand disease, first we have to recapitulate von Willebrand factor. Von Willebrand factor, it is glycoprotein in nature. It is glycoprotein in nature. It is named as von Willebrand according to name of scientist Erich von Willebrand. Named according to name of scientist Erich von Willebrand. So, according to the name of scientist Erich von Willebrand, it is called von Willebrand factor. It is glycoprotein in nature. Normal plasma level of von Willebrand factor is about 10 milligram per liter. About 10 milligram per liter. Half-life of von Willebrand factor is about 5 to 15 hours. Now come to the source of this glycoprotein, from where it is synthesized. Source of von Willebrand factor, from where it is synthesized. The sources are Willebrand bodies of endothelium. If this is blood vessel, if this is endothelial lining, there is Willebrand bodies within this endothelium, and this is the source of von Willebrand factor. Another source is alpha granules of platelet. So platelet is another source of this von Willebrand factor. The another source is megakaryocyte. Megakaryocytes. You know, megakaryocyte is present in bone marrow, and this megakaryocyte is the source of von Willebrand factor. After synthesis or secretion of von Willebrand factor, where we can get von Willebrand factor? Von Willebrand factor is present where it is present in plasma. It is present in subendothelium of blood vessel. Subendothelium of blood vessel. If this is the vessel, blood vessel, this is tunica media, tunica adventitia, and this is the lining endothelium. So this von Willebrand factor is present in blood, in plasma, also in subendothelium. It is also present in combination with factor 8 coagulation factor. Dear audience, you know factor 8 anti-hemophilic factor is present in blood. The half-life of factor 8 in blood is about 2 to 3 hours. When it combines with the von Willebrand factor, the half-life is increased. So von Willebrand factor stabilizes factor 8 when it combines with the factor 8. When von Willebrand factor combines with factor 8, the factor 8 is stabilized. Factor 8 is stabilized. Now come to what is the role of von Willebrand factor. Role of von Willebrand factor. Role of von Willebrand factor. First and foremost role, it helps in hemostasis. It helps in hemostasis. It helps in hemostasis. How it helps in hemostasis? How it helps in hemostasis. It causes platelet adhesion with the subendothelial collagen of blood vessel. Causes adhesion of platelet with subendothelial collagen, and it stabilizes factor 8. Factor 8. So by making addition between platelet and subendothelial collagen and by stabilizing factor 8, it helps in normal hemostasis. Dear audience, suppose this is the blood vessel. This is blood vessel. Then is the tunica media, and this one is the tunica adventitia, like here. And this is the lining endothelium. Lining endothelium. If injury here with blood vessel, there will be hemorrhage. There will be hemorrhage. So there will be hemorrhage. During normal hemostasis, at the injured part of the blood vessel first constrict. Blood vessel first constrict. As there is injury, there is exposure of subendothelial collagen fiber. Exposure of subendothelial collagen fiber. Now come to mechanism of hemostasis by von Willebrand factor. Following vascular injury, what happens? There is exposure of subendothelial collagen fiber. Exposure of subendothelial collagen fiber. Exposure of subendothelial collagen fiber. And you know, as there is injury to the endothelium, there is release of von Willebrand factor. And you also know in the subendothelial space there is also von Willebrand factor. Following injury, there is exposure of von Willebrand factor also, and release of von Willebrand factor from the endothelium also. So, following injury, following vascular injury, subendothelial von Willebrand factor is exposed, and release of von Willebrand factor from injured endothelium. Suppose this is the von Willebrand factor. These are the von Willebrand factors. The black one are the von factors. Black one are the von factors. These are exposed. The von Willebrand factor then makes bridge or cross links between the collagen fiber and the platelet. What happens? This exposed von Willebrand factor, the von Willebrand factor makes bridge between collagen and platelet, because platelet has receptor glycoprotein 1b for von Willebrand factor. Platelet has receptor glycoprotein GP1b for von Willebrand factor. As platelet has a receptor for von Willebrand factor, so the von Willebrand factor makes bridge between collagen and platelet. Suppose this is the platelet, these are the platelets. Now the platelet, with the help of von Willebrand factor, is with adherence with the collagen fiber, and this is called platelet adhesion. After adhesion, after adhesion of platelet is activated. So when the platelet undergo adhesion with the help of von Willebrand factor with the collagen fiber, the platelet become activated. From the activated platelet, followings are followings are released. What are those? ADP. And the activated platelet expresses another receptor GP2B3A. GP2B3A. This is another receptor expressed on activated platelet. And due to expression of this another glycoprotein receptor 2B3A, this receptor makes bridge between activated platelet and fibrinogen. Now come to, on the surface of the activated platelet there is GP2B3A receptor. Due to presence of this receptor, fibrinogen binds here, and this is the fibrinogen. So fibrinogen binds with the GP2B3A receptor on the activated platelet. Fibrinogen binds with GP2B3A receptor, and this fibrinogen cross-links with the other platelets. It cross-links with the other platelets. These are the fibrinogen, other platelets. As there is cross-linkage between the other platelets with the activated platelet, there is aggregation of platelet. So there is aggregation of platelets. This fibrinogen cross-links with other platelets. So ultimately there is formation of aggregation of platelet. This aggregated platelet along with the fibrinogen is called platelet plaque. So there is formation of platelet plaque. Keroidins, again we recall, after injury of the endothelium, exposure of the von Willebrand factor from the subendothelium, also from the injured endothelium. This von Willebrand factor binds with the platelet because the platelet contains receptor GP1B. This is called adhesion of platelet. After adhesion of platelet undergo activation. Due to activation of platelet, there is release of ADP, expression of another receptor 2B3A, and this receptor binds with the fibrinogen. Then fibrinogen cross-links with the activated platelet and other platelets and made platelet aggregation. This aggregated platelet along with the fibrinogen is called platelet plaque, and this platelet plaque is unstable. What happens then? Later on in this area, the factor 8, that is along with the von Willebrand factor, activates factor 10 in intrinsic coagulation cascade. Factor 8 present with von Willebrand factor, that is the factor 8 that has been stabilized by von factor activates factor 10 in the intrinsic pathway of coagulation cascade. So in this area, factor 8 that was present with the von Willebrand factor activates factor 10, and ultimately conversion of fibrinogen to fibrin. Once this fibrinogen is converted to fibrin, then this is a no more unstable plaque, and this is called blood clot, and ultimately there is formation of blood clot. And so there is arrest of bleeding, so there is hemostasis. So this is the role of von Willebrand factor, how it helps in hemostasis. Dear audience, now come to von Willebrand disease. Von Willebrand disease. First, we have to know what is von Willebrand disease. Come to definition of von Willebrand disease. It is an autosomal dominant. It is an autosomal dominant inherited hemorrhagic disorder due to quantitative or qualitative defect of von Willebrand factor. So it is an autosomal dominant inherited hemorrhagic disorder. Why disorder? Due to quantitative or qualitative defect of von Willebrand factor. It is a common inherited hemorrhagic disorder. A common inherited hemorrhagic disorder. It is about 1% or 1% of population is affected. About 1% population is affected. So what happens in von Willebrand disease? What about the plasma level of von Willebrand factor and factor 8 in von Willebrand disease? In von Willebrand disease, what happens? In von Willebrand disease, there is deficiency of von Willebrand factor or defective von Willebrand factor and low level of factor 8 in combination with von Willebrand factor. Low level of factor 8 in combination with von Willebrand factor. Dear audience, if anybody suffers from von Willebrand disease, there is either deficiency of this factor or defective of this factor. At the same time, the patient plasma is sufficient with factor 8, but in combination with the von Willebrand factor, the factor is low, because this factor, this von Willebrand factor stabilizes factor 8. As it is deficient or as it is defective, so it cannot stabilize the factor 8 sufficiently. So in combination with this factor, factor 8 is low, although plasma level factor 8 is sufficient. Now come to pathogenesis of von Willebrand disease. Pathogenesis of von Willebrand disease. Dear audience, von Willebrand factor is synthesized by platelet megakaryocyte endothelium, you know, and this synthesis is encoded by a gene, and that gene is present in autosome in 12 chromosome. Gene that encodes von Willebrand factor is present in chromosome 12. We can recall the gene that encodes factor 8 is present in X chromosome, but the gene that encodes von Willebrand factor is present in chromosome 12. It is autosomal dominant. Autosomal dominant pattern of inheritance. So it is single gene mutation of the gene that encodes von Willebrand factor. So mutation of gene in chromosome 12 that encodes synthesis of von Willebrand factor. As there is mutation and as it is autosomal dominant, it is single gene mutation. Due to mutation of this gene, either there is decreased synthesis of factor or sufficient synthesis of factor, the factor is defective. What happens? Either due to mutation, what happens? Either one is decreased von Willebrand factor synthesis or defective von Willebrand factor synthesis. When there is decreased von Willebrand factor synthesis or defective von Willebrand factor synthesis, what happens? If so, when decreased von Willebrand factor or defective von Willebrand factor, what happens? Number 1, no adhesion of platelet in subendothelial collagen fiber. No addition of platelet with subendothelial collagen, as no addition, no platelet plaque formation. As there is no platelet plaque formation, what will happen there? As there is low level of this factor or defective factor, the factor 8 in combination with the von Willebrand factor is minimum. So low level of factor 8 in combination with von Willebrand factor. As low level of factor 8 in combination with von Willebrand factor. Again we recall von Willebrand factor stabilizes factor 8. In the intrinsic pathway of coagulation cascade, there will be no conversion of fibrinogen to fibrin, and ultimately there will be increased partial thromboplastin time. Again, as low level of factor 8 in combination with von Willebrand factor, there will be no activation of factor 10, and ultimately what will happen? The increased partial thromboplastin time, increased PTT. As low level of factor 8, no activation of factor 10, so ultimately increased partial thromboplastin time. Now come here again, as no addition of platelet, no formation of platelet plaque, so there will be increased bleeding time, prolonged bleeding. So due to deficiency or defective von Willebrand factor, as there is no addition of platelet, so there is prolonged hemorrhage. And as there is low level of factor 8 in combination with von Willebrand factor, so there is increased PTT, ultimately increased APTT. Again we recall, due to low level of von Willebrand factor or defective von Willebrand factor, there is no addition of platelet, so there is no arrest of bleeding, so there is prolonged bleeding, prolonged hemorrhage. And as there is no activation of coagulation cascade due to low level of factor 8 in combination with this von Willebrand factor, so there is increased partial thromboplastin time, that is increased activated partial thromboplastin time. This is the pathogenesis of von Willebrand disease. Dear audience, now come to clinical presentation of von Willebrand disease. Clinical presentation of von Willebrand disease. E.g. bruise, elsewhere. Mucosal bleeding like epistaxis, nasal bleeding. This epistaxis nasal bleeding is aggravated following upper respiratory tract infection. It is aggravated following upper respiratory infection. Incisional bleeding. If you give incision, there will be profuse bleeding. Oral bleeding. For long time following tooth extraction. Again, oral bleeding for long time following minor surgery in oral cavity. There may be menorrhagia. So these are the clinical presentations. Dear audience, if anybody suffers from von Willebrand disease, and you know it is a common hereditary hemorrhagic disorder, if the individual takes aspirin, the hemorrhage will be aggravated. Now come to types of von Willebrand disease. One is type 1. It is mild type. It is mild type. Decreased von Willebrand factor. Here von Willebrand factor is decreased. How much decreased? About 50% is decreased. Type 2. Here no decrease of von Willebrand factor. The plasma level of von Willebrand factor is almost normal, but the von Willebrand factors are defective. So defective von Willebrand factors. Type 3. It is very severe type. It is very severe type of von Willebrand disease. What happens here? Here almost complete suppression of synthesis of von Willebrand factor. Almost absence of von Willebrand factor. Dear audience, I have told you it is autosomal dominant pattern of inheritance of inherited diseases, but type 3, where there is almost complete or complete absence of von Willebrand factor, it is autosomal recessive pattern of inheritance. It is autosomal recessive pattern of inheritance. Autosomal recessive pattern of inheritance. This is all about the types. Now come to laboratory diagnosis. We have to do first bleeding time. Bleeding time is prolonged. We know 5 to 11 minutes is normal. Bleeding time is prolonged. Hours together. It may be hours together. Then we have to do total platelet count. Dear audience, you know in thrombocytopenia there is prolonged bleeding time. Here prolonged bleeding time in spite of normal total platelet count, because due to defective or deficiency of von Willebrand factor there is no platelet addition, so there is prolonged bleeding time. So we get total platelet count is normal. In spite of normal total platelet count, why bleeding time is prolonged? Because due to deficiency or defect of von Willebrand factor, there is no addition of platelet to arrest bleeding. Then we have to do prothrombin time. Prothrombin time is normal. Prothrombin time is normal. Then we have to do activated partial thromboplastin time. It is prolonged. It is prolonged. We get activated partial thromboplastin time prolonged and increased in hemophilia. Here we are getting APTT prolonged. Why? I have told you von Willebrand factor stabilizes factor 8 for 12 hours. As this factor is deficient or defective, it cannot stabilizes factor 8. So there is APTT is increased. Then we have to do ristocetin cofactor assay. Dear audience, now come to ristocetin cofactor assay. Ristocetin is nothing but an antibiotic. It is an antibiotic. It is an antibiotic, and this antibiotic ristocetin helps von Willebrand factor to bind with the GP1B receptor present on the platelet. It helps von Willebrand factor to bind with glycoprotein GP1B receptor on platelet. So this antibiotic ristocetin helps von Willebrand factor to bind with GP1B receptor present on platelet, and so it helps in platelet aggregation. It helps in platelet aggregation. If we get decreased platelet aggregation on addition of ristocetin, if we get decreased platelet aggregation, it is diagnostic of von Willebrand disease. So decreased platelet aggregation is diagnostic of von Willebrand disease. This is all about the von Willebrand disease. Dear audience, I can recall I have told you about the von Willebrand factor. It is glycoprotein nature. It is synthesized from the platelet megakaryocyte endothelium. It is known as von Willebrand according to the name of scientist Eric von Willebrand. This von Willebrand factor is synthesized with the dictation of gene present in chromosome 12. The role of factor helps in normal hemostasis. How? It helps in platelet adhesion and helps to stabilize factor 8. And it is a common hereditary hemorrhagic disorder due to either quantitative defect or qualitative defect of von Willebrand factor. Whatever may be the defect, either deficiency or defect, there is no addition of platelet. As there is no addition of platelet, so there is prolonged bleeding time. As there is no sufficient stabilization of factor 8 due to low level of or defective vulnerable factor. So intrinsic pathway of coagulation cascade is not activated, so there is increased partial thromboplastin time, that is increased activated partial thromboplastin time. It is 3 types: type 1, type 2, type 3. Type 3 is autosomal recessive pattern of inheritance. It is severe form. There is complete absence or almost complete absence of factor. In type 2, although there is factor, the factors are defective. In type 1, there is decrease in about 50%. And we can diagnose in laboratory by doing bleeding time, total platelet count, prothrombin time, APTT and histocin cofactor assay. Today up to this, thanks all.